You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandroa from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 24th, 2025. This week, familial hypercholesterolemia, cardiac arrest therapy, factor XI inhibition, and more on tricuspid valve interventions. I first want to say thank you to the University of Michigan Fellows for inviting me to give cardiovascular rounds there yesterday. It is an honor to be asked to speak anywhere, but it is an especially big honor to get a Fellows invite. I spoke on atrial fibrillation therapy, focusing on areas of uncertainty. It was also great to see my friend Venk Murthy, who's a true academic. All right, first topic today is familial hypercholesterolemia. When I started cardiology many years ago, getting the diagnosis of FH was terrible. Early coronary disease and cardiovascular death was highly likely. But things have changed for the better. So suggests yet another neat observational comparison study using that national treasure, the Danish Health Registry. The first author is Jacob Rie, and co-authors from the Gentofte Hospital in Copenhagen, which I've visited. They use the registry to compare about 11,000 patients with and 9 million without FH over a 45-year period dating back to 1978. During follow-up, 27% of those with and without familial hypercholesterolemia died. And the key findings for individuals with FH compared to those without, the mean age at death was 22 years younger in 1978, but in 2021, the corresponding difference in mean age of death was only 1 year, 78 versus 79 years. And when you look at a graph with age at death on the y-axis and years on the x-axis, the two curves are separate in 1978, but they gradually come together by 2021, and the relationship was the same in men or women. However, interestingly, the age of coronary artery disease diagnosis do not completely come together. For individuals with FH compared to those without, the mean age of coronary artery disease diagnosis was 20 years younger in 1978, 49 versus 70 years. But in 2021, the corresponding difference in mean age was reduced to 7 years. It was 61 versus 68 years, and that difference of 7 years was still statistically significant. Now, there were similar patterns seen with ACS diagnosis and angina diagnosis. So my comments, here we have another example of a good use of observational data, that is, describing trends over time, or as we say, temporal trends. It also presents good news. A once terrible disease has now been essentially normalized. What's more, it is fun to speculate on why the diagnosis of CAD, angina, and ACS have not completely normalized while the age of death has. The authors do something that I haven't seen before, but I really like. In the discussion section where they speculate, they write, quote, importantly, the ideas presented below should be interpreted cautiously as we are not presenting data to support such speculations, end quote. They actually write that sentence twice, I think for emphasis. I don't know why they think it is controversial because lots of diseases have declining incidence. For instance, I covered declining stroke rates in patients with AFib from the Finnish registry last week, and I'll write more about that. And I have mentioned the declining incidence of sudden death in patients with heart failure. Here, I see it as likely that the diagnosis of FH will increase, but as treatments improve, like statin use, we would expect to see death rates decline. I think it's a great example of how domain affects treatment effect. What do I mean by domain? Well, one domain is the risk of an event, that is the coronary heart event. Now that's very high in FH. Opposing the risk of the primary event, which is ACS, is the competing risk of other things. And here, FH patients are diagnosed younger, and they don't have a lot of competing risks. Another domain that affects treatment effect is the treatment benefit of the therapy. Well, in this case, we know that statins are effective and they have little harm. The authors tell us in the discussion section that the use of statins increased over time from 46% in 1995 to 77% in 2021, whereas the rates of statin use went from 0.7 to 12% over the same time in patients without FH. Another factor or reason why the age of death is probably normalized in FH is that the treatment of coronary disease has surely improved. I mean, stents have replaced plain old balloon angioplasty. Second-generation stents are better than first-generation stents, for instance. And finally, a reason that the diagnoses have not completely normalized is that coronary diagnosis is much improved in recent times. We have high-sensitivity troponin is more sensitive than the older biomarkers. We now have CT scans that pick up coronary disease. And if more and more patients are diagnosed with FH by cascade screening of a relative, then having the diagnosis of FH will surely make it more likely to be diagnosed because we're looking for coronary disease in these patients. I covered this observational study because I wanted to start the podcast with good news. Since so often I tell you a story of dubious data or dubious data interpretation, this is good news. The second topic deals with out-of-hospital cardiac arrest, specifically the route of drug administration in out-of-hospital cardiac arrest. Few areas of medicine seem better at generating proper evidence than the resuscitation space. I wish general cardiology did this many proper RCTs. Resuscitation doctors and scientists are really good at RCTs. New England Journal of Medicine published an RCT comparing intraosseous versus IV access during a cardiac arrest. I realize that acute care of cardiac arrest is a bit out of my lane and maybe yours too, but I cover this trial not only for the specific question, but also because of what it says about EBM, evidence-based medicine. First author is Mikkel Valentin from Aarhus, Denmark, and of course this is a Danish study. As background, and from my reading, I read that guidelines recommend initial attempts at IV access, but the authors write, quote, despite this recommendation, the use of intraosseous access is increasing, end quote. And they also say that a systematic review of observational studies showed that patients who received meds by an intraosseous route during cardiac arrest had worse outcomes than those who received medication intravenously, but of course this could be confounded. Well, the way to sort this question out is not more observational studies or trial emulations, but just randomize. And so they did. About 1,500 patients were randomized to the two routes of initial IV access. Their primary endpoint was return of spontaneous circulation. The results? The first finding was that 92% of the intraosseous group had successful access versus only 20% of the IV group. Sustained return of spontaneous circulation occurred in 30% of the intraosseous group versus 29% in the IV group, and the risk ratio was 1.06, and it's essentially no statistical difference. Secondary outcomes, including survival at 30 days or favorable neurologic outcomes, were also not different. The authors also randomized humeral versus tibial intraosseous access. I actually didn't know you could do intraosseous access in the humerus. There was no difference here in return of spontaneous circulation. But CT scans done at the hospital showed that 100% of intraosseous catheters were correctly placed in the tibia versus only 71% of humeral catheters. The authors concluded simply that there was no significant difference in return of spontaneous circulation with either of the two methods. Okay, comments. Well, you or I are not out in the field resuscitating people. Most of the cardiac arrest that we see is in the hospital and patients have IVs. This is a really nice example of how to answer questions in medicine. That is, you randomized. Now, the resuscitation people know that there is unlikely to be a difference in outcomes with either access point. Just get access and give epinephrine as soon as possible. In this trial, time to first dose of epinephrine was similar in both arms, and the authors tell us that this is likely the reason for equivalent outcomes. That the trial happened in Denmark is also not a surprise, as the medical community and perhaps the general population accept equipoise in randomized trials there. When I visited University of Michigan yesterday, we talked a lot about trying to change the culture of U.S. medicine to be more accepting of randomization. For if we had such a culture, we would know a lot more about what works and what does not. Now, for instance, the lack of knowledge in the left atrial appendage occlusion space comes immediately to mind. Hundreds of thousands of these devices have been implanted in patients who were excluded from the seminal trials, and so we have no idea if they work. All because we have not done what Danes seem to be really good at, and that is RCTs. Also notable in this paper's data sharing statement, quote, will the data collected for your study be made available to others? Answer, yes. That is the right answer, so I say congratulations to the Danish authors. All right, next topic is factor 11 inhibitors may not be dead yet. New England Journal of Medicine has published the results of Azalea TIMI 71 trial. This was a phase 2 trial of the monoclonal antibody abelacimab versus DOACs in patients with atrial fibrillation. First, some background, which most of you probably know. The DOAC drugs are quite good at preventing stroke and are non-inferior to warfarin in efficacy. They are superior to warfarin at preventing intracranial hemorrhage, but DOACs still have an increase in bleeding, especially GI bleeding. Factor 11 inhibition holds promise to be an effective oral anticoagulant, that is, prevention of stroke, and have lower bleeding risk. Because there is mounting evidence that factor 11 is essential for thrombosis, but non-essential in most cases for hemostasis, and persons with genetically mediated factor 11 deficiency have fewer embolic events without an appreciable increase in the occurrence of spontaneous bleeding. However, a previous factor 11 inhibitor, asundexian, also showed lower bleeding rates versus DOACs in phase 2 trials, but failed to be an effective stroke preventer. The Oceanic trial of asundexian versus apixaban was stopped early because of a nearly 4-fold higher rate of stroke in the active arm. Abelacimab looked strong in a phase 2 trial of patients having knee surgery, where a single IV dose after surgery reduced the rate of venous thromboembolism by 80% compared to enoxaparin without increasing bleeds. So the results, again, of this phase 2 study of about 1,300 patients who underwent 1:1 randomization of abelacimab 150, abelacimab 90, or rivaroxaban. These were 74-year-old patients with a mean CHA2DS2-VASc of 5. Since this was a phase 2 trial, the primary endpoint was major bleeding, and the trial was stopped early because of a greater than anticipated reduction in bleeding events with abelacimab. The incidence rates of major or clinically relevant non-major bleeding was 3.2 events per 100 person years with 150 abelacimab, 2.6 per 100 person years with 90 milligrams of abelacimab, as compared with 8.4 per 100 person years with rivaroxaban. The hazard ratio for 150 milligrams of abelacimab versus rivaroxaban was 0.38. The hazard ratio for 90 milligrams of abelacimab versus rivaroxaban was 0.31. Those are both statistically significant and much better, much lower rates of major bleeding with the factor 11 inhibitor. The trial was not powered for stroke events, which are much lower in incidence than bleeding. Note the DOAC trials had more than 10,000 patients, as well as previous asundexian versus apixaban trial had 14,000. You need more patients to study efficacy of these drugs. And there were only 28 stroke or systemic embolism events in this trial. But the event rates were slightly lower, numerically lower in the rivaroxaban group versus the abelacimab 150 and 190. The event rates were 7 versus 10 versus 11, and this was driven by ischemic stroke rates, which were 5 in rivaroxaban versus 10 in the abelacimab group. These are obviously small numbers and wide confidence intervals, but again, numerically higher in the factor 11 arm. So my comments, obviously the question is whether abelacimab will face the same fate as asundexian. It's great in phase 2 trials and flop in phase 3 trials because it fails to reduce thrombotic events. That's the question. The authors spend a paragraph telling us that there are important and favorable differences between abelacimab compared with the Sundexian. I won't list them all because there is now only one question. Does this drug work in phase 3 trials versus DOACs? And for this, we have to wait for the results of those trials. I want to make a side note here from an EBM perspective. I am struck by how much more rigorous drug development is than devices. I realize that device trials can never enroll as many patients as drug trials, but when a phase 3 trial of abelacimab comes out, we're going to have a good idea of whether it works. We'll have phase 2 data, and then we're going to have a big 14,000 patient trial with factor XI inhibition versus DOACs. This sort of knowledge is less common with devices, but it doesn't have to be. The answer, in my opinion, is to approve a device for use if the regulatory trial is reasonably assuring, but then require proper phase 4 trials soon after approval. Such an approach would not penalize first-generation devices and would allow for continuing knowledge generation. We don't have that with left atrial appendage occlusion, and we went 15 years without it with Impella. Again, I think it's possible to do proper trials. We just have to have the will to do them. And speaking of proper trials, the next topic is the JAK and the tricuspid valve. Last week, the Journal of the American College of Cardiology had a focus issue on one expensive and new drug, the whole issue, finerenone. This week, JAK focuses on tricuspid valve interventions. As many of you know, I've been highly critical of the tricuspid valve evidence generators because of their highly soft trial design, namely, not having a proper surgical placebo arm and then using subjective patient measures to assess efficacy. So the first study in this JAK focus issue is the Triluminate full cohort study. Recall that the Triluminate study was transcatheter edge-to-edge repair with the TriClip system versus tablets. And this full report included 600 patients. So said another way, 600 patients were experimented on, and the primary endpoint choice tells us a lot about the trial design. The primary outcome of Triluminate was a hierarchical composite of death or tricuspid valve surgery, heart failure hospitalization, and quality of life improvement measured by the KCCQ questionnaire at 1 year, and was also analyzed by a win ratio. And of course, it was positive. The 1 year report was positive, just like the main trial reports were positive. This particular paper involved the whole full randomized cohort, whereas the previous paper was part of the cohort. And so the results are the same, a positive win ratio, but no difference in death, valve surgery, or heart failure hospitalizations. All of it was a change in KCCQ, but again, no placebo arm. This is mind-boggling to me. However, fortunately, now my view has got some support from inside the gates of the institution. Drs. Levy, Singh, and Greg Stone wrote an editorial that dared to question the value of this intervention. They cite the fact that in COAPT, the MitraClip trial, that large improvements in the KCCQ correlated with heart outcomes, whereas there was no correlation in Triluminate. The editorialists conclude that the discordance in quality of life measures and heart outcome causes, quote, uncertainty of benefit as to the true magnitude of benefit of this promising therapy. Now, I would substantially change that wording. I would say that having a primary endpoint of a subjective nature without a proper placebo doomed this trial to fail. You cannot compare a big procedure to tablets. It belies basic science 101 principles. You need a placebo. That it was not done makes me cynical that the industry-sponsored trial was not actually a science exercise, but a marketing exercise. That academic doctors and FDA went along with it is sad. Now, the wording I would use is that the discordance in quality of life measures and heart outcomes in Triluminate causes uncertainty of benefit as to whether there is any benefit. If I were at FDA, I would make the company do a proper trial. A sham arm would have been so easy to do with this procedure. Now, my libertarian friends might say that the FDA should approve devices like this and let the market decide. And I'm sensitive to that idea because in a proper world where doctors could adjudicate evidence, Triluminate would convince no one. The device would be considered low in value and not used until there was a proper trial showing it effective. But, at least in the US, such a world is like a fantasy world. It doesn't seem to happen. We have incentives to do this procedure. That includes financial rewards, as well as if you do a lot of these procedures, you become a top person in the field. The whole thing is sad. Sad, sad, sad. Now, speaking of more sadness, the TRISCEND trial has reports on quality of life. Also in this issue, the TRISCEND investigators present a similarly weak RCT comparing the tricuspid valve replacement called the EVOC versus tablets. This open-label, non-placebo-controlled trial had a similar composite endpoint, and once again, the win ratio favored the valve. Of course it did, because of the favorable quality of life data. TRISCEND was even worse than Triluminate because not only were there no differences in hard endpoints of death or heart failure hospitalizations, there was a nearly 3x higher rate of bleeding in the valve arm, as well as a 9x higher rate of pacemakers needed, which is not a small thing because this requires special pacemakers. You have to either do a CS lead or a leadless pacemaker. Now, this new report focuses only on quality of life. Of course it does, because it's positive, and is similar to the main report. My comments are the same as I just said. The whole thing is sad. The JACC issue also includes a German observational study called the PACE Registry. The PACE Registry is about 1,000 patients who are treated with the Pascal transcatheter edge-to-edge repair system. The good news, and you should always check for this, the registry included consecutive patients. That's important in registry studies because voluntary registries are about as useless as can be, as investigators might not include their bad cases. The results of the PACE registry show that the device performs reasonably well in reducing TR, and the second-generation device was better. That's good. I say good. They also report on clinical outcomes, but these are useless without a control arm. And I may have missed it, but I did not see a list of complications of this device. The authors write that there were no major complications, but I'd like to know what were any complications. As I have said, registry studies are fine to describe what happens, and so this is fine. Here's my question, though. There were 1,000 patients in this registry. Imagine what we could have learned if these were randomized with a proper placebo arm. We would then know how effective this device is. The JACC edition also includes an imaging sub-study of Triluminate. I don't think it helps. Of course it doesn't help because it's unblinded and you can see that there's a clip there. We need outcomes and we need proper placebo controls. But there is an excellent editorial from Drs. Gupta, Yang, and Rasha Al-Lami. They address, in quite soft language I should say, the lack of benefit in hard outcomes with these devices, the problem with no placebo control or sham arm, as well as the problem that's going to happen, which is selecting patients with TR who should have these procedures. Because keep in mind, and they write about the issue of causing RV failure because of afterload mismatch. This is an important thing in treating regurgitant lesions, that you can, by taking the afterload reduction away, cause heart failure or ventricular failure. The editorialists write, and I quote, future trials must incorporate placebo controls to quantify the true benefits of these interventions, and they should use longer-term follow-up to assess device durability and survival. Additionally, head-to-head comparisons of transcatheter edge-to-edge repair and transcatheter valve replacement are needed to better inform patient selection and refine treatment strategies. The problem that I see, at least in the US, is that once this device is on the market and CMS agrees to pay for it, which they haven't exactly yet, there's equipoise that's going to be shredded, and there's not going to be a way to do a trial. The device is just going to be used, and that too is sad. Now, I want to finish this podcast by adding my disclaimer on devices. I suspect, as I did with Impella, that there may be highly selected, even rare patients who have TR who could benefit from a transcatheter edge-to-edge repair or a device replacement. But if the device is not approved and it's not on the market, these few patients who could benefit can't benefit. But on the other side of the coin, the flip side, is that we have a hugely prevalent condition of TR, and then we're going to have marketing forces and incentives for doctors to do these procedures. So the risks of letting this device on the market is huge. So that's why, if only the FDA and clinical sciences had followed the advice of Professor Al-Labni and done proper placebo-controlled trials, then we would know the true improvement with these devices. And I'm sorry to be so sad about this. If you can say something to me that would pick me up, I'm happy to hear it. So let me know what you think. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. If you don't agree with something I said, let me know. I learned from these comments. Until next week, this is John Mandroa from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.